Louise.
Okay, so it all began in March 2014. I was called in to assist the surgeon with a mitral valve replacement and coronary artery bypass grafts on a patient who was obese with bilateral varicose veins. Two of my colleagues had been hard at it searching for suitable conduit for quite some time. Luckily, by the time I took over, the patient was off bypass and the protamine was about to be given. Suddenly, the vein graft ruptured and the patient had to go back onto bypass. I had to harvest the radial artery on a fully heparinized patient. The tissues were edematous, it had already been a long bypass time, and the arm bled like stink. The radial artery was grafted onto the ruptured venous territory, and eventually the patient arrived on critical care at 1 o'clock the following morning. So, could this have been avoided? Well, after discussing this case with colleagues and reviewing the literature, ultrasound vein mapping was identified as an effective way of assessing the anatomy and the quality of conduit preoperatively. Knowing we have this equipment within the theatre department, I was shown by one of the anaesthetists how to use it. After a period of practice and developing my skills along with my colleagues, I conducted a pilot study of 5 patients and presented it at the surgical meeting where it was well received. From that I went on to run an audit for 12 months. During this time along came Mrs. B. She was an 86-year-old lady who, amongst other things, had previously had bilateral mastectomies for CA breast and radiotherapy to her chest wall. She was booked as an in-house surgeon for coronary artery bypass grafts using 3 venous vein grafts only. She had an intra-aortic balloon pump in situ, so due to her semi-recumbent position, could not have her veins assessed properly. However, there were no obvious concerns. She later remembered having a vein stripped 50 years ago. To confirm this, one of my colleagues scanned her legs. This showed no veins present in the long and short venous regions bilaterally. She was referred on to the interventional cardiologists where she had stents and rotor ablation with a good result. So, vein mapping for surgical revascularisation. Should it be a standard of care? Well, let's find out. This brings me nicely onto my audit. 87 patients were included in the audit. 3 patients had their scans stopped early, so will only be included in some of the data. The reason for this was the anaesthetist needed the ultrasound machines for CVP line insertion. 74% of the patients were male, 26% female. Scanning events by surgeons demonstrated one surgeon had a particular interest in ultrasound vein mapping. The other surgeons requested scans when they preempted difficulties with the conduit harvest. 62% of patients were scanned in the anaesthetic room, 22 on the ward, 15% in theatre and 1% in recovery. 7 minutes was the average time to scan one leg, going to a maximum of 25 minutes, and 17 minutes was for both legs with a maximum of 45 minutes. 63% of legs scanned resulted in a change of strategy or aided the procedure, and 37% showed no change in strategy. 38%, that's 33 patients, showed no change. However, 62% showed a variety of outcomes. The 5 most common ones being 19% showed a change of location in the leg, 10% showed a change of leg, 10% aided bridging. In fact, here's an example of a bridged leg. The ultrasound allows us to identify and mark tributaries along the vein so we can better place our incisions. And 5% shows both legs used instead of one. And I'll give you a few moments to take in the rest. And here's an example of a leg that's had open vein harvest. And this next picture demonstrates how the vein is located using ultrasound and an initial incision made around the knee when harvesting vein endoscopically. And when we consider how surgery was avoided for Mrs. B, it was quite the opposite for Mr. R. He was a 79-year-old gentleman who had high tie and stripping of his varicose veins many years ago. I was asked to review this patient by the consultant. If the scanning had shown no suitable conduit, then the patient would have been referred to the interventional cardiologists. The ultrasound did identify suitable segments of vein, and the patient went on to have coronary artery bypass grafts with a good result. So there are benefits to ultrasound vein mapping. It's not invasive, it's cheap, it identifies the anatomy and quality of conduit. Patients can be lying or standing and they take an interest in what we're doing. There is a learning curve, however, but when you know where you're going, the journey's quicker. So, in conclusion, what I have shown is assessing the vein using ultrasound benefits patients to the extent that it can determine whether a patient has an operation or not. Availability of equipment can be a problem, but a vein mapping service can be provided given the appropriate resources, time and training. So my question to you is, when there was a time when we looked at the stars to guide us where to go. Then we refined our skills, harnessed new tools and moved on to using a compass. We moved on even further, and now we use an A to Z. And when I presented this first to the team at Papworth, I asked them, do we want to be sent to Coventry or to stay at Papworth? Apologies to anyone from Coventry. And in a similar vein, we used Gray's Anatomy for years, but I think the time has come to use ultrasound vein mapping. Thank you.
Fantastic. Questions from the floor?
Thank you for a great presentation. I'm SCP from Plymouth, and we've used vein mapping on occasions when we think we're going to have difficulty. And you've shown that there's clear case we could do it routinely. Have you been able to use your evidence to actually buy more equipment so you've got it available?
I've been working on that for the last 2 years, and at the moment the business case is with the Director of Nursing at Papworth, and I'm hoping in the next financial year we'll have, I did ask for 5 portable machines of our own that we've sourced and trialled, and they're perfect. So I'm just waiting to find out, but the Director of Nursing was very supportive when I presented this at the hospital-wide audit. Yeah.
Any more? Well, lots of questions. In the front here.
Hi, I'm Jill Lay from San Francisco. 2 things. Number one, we kind of have a 60-40 rule in the United States. If something shows benefit 60% of the time, the insurance companies tend to go along with it, more so without this sort of data. So this is outstanding. Second point I would make is that endovascular vein harvest has become really the standard of care in the States, and that has cut our leg wound infection rate down to single digits. So I think that's some more cost savings that you might be able to build into your program.
Yeah.
Are the people that are doing EVH routinely, Camilla and team, are you all vein mapping? Or do you ultrasound first? No. Yeah.
Past 6 years we are doing it. From 2006 I'm doing endoscopic vein harvesting. We regularly scan our legs, and our other surgical care practitioners, when they started for past 5 years, we do it. The one way how we didn't get cost on all the problems is we use the anesthetic machine. The anesthetists, they use it over there, so before they take it, when they're putting lines, we map them. So it won't take, I don't know why it's taking long time for you, but by experience it will be, you will be get more better and better, so that time you don't need to buy a new machine.
Well, the problem is, when we want to scan the legs, the anaesthetists need them for the neckline insertion, and I've fallen out with quite a few over the last 2 years about this. I was thrown out of one anaesthetic room once. I'll never do it again. And my ideal would be to either vein map the patients on the ward, you can get them to stand up. So, because when you get beyond the knee, you need to fit the probe perpendicular to the leg. So usually they're lying on the operating table, they're slightly hypotensive because they're anaesthetised, their head down, So it's slightly more difficult to identify the vein or get a true picture of how the vein is distended. There was one trial done by Heyman Lucraz, and their research, they used to tie a tourniquet around the thigh in the anaesthetic room to get a true picture of the calibre of the vein once in the distended form, so to speak. So I would either ideally like to do it on the ward preoperatively or in pre-admission clinic and have like a pro forma in the notes where it can be formally mapped and written on in the notes.
Some more questions? Yeah, I've got one.
I'm from Southampton. Did you do any training for vein mapping?
I'll tell you about the training. Found a machine. I said to one of the anaesthetists, how do you turn it on and off? How do you set it up? How do you work the depth? And I went to recovery and practiced on my leg for an hour, and then I got some of my colleagues, got them into an empty anaesthetic room on an audit day and practiced on their legs, and that's how we've done it. But if we can get some machines of our own, I will take myself off to the nearest hospital, vascular, that does vascular surgery, probably Addenbrooke's in this case, and see if I can spend a day in the vascular labs to learn how to do it properly. But what we've seen that how we started it, we would scan the legs and then do the open vein harvest and see how how did we see it on the ultrasound machine and how does it compare to what we actually see when we open, and we realised that we were actually getting it right most of the time.
Question there, yeah.
Thank you, Louise. It was a great presentation. Just one question: your surgeon who has a particular fancy for the ultrasound. Is there any correlation between their outcomes and the rest of their colleagues? I mean, are they doing it too much, or are the others not doing it enough? You seem to be a particular outlier.
Well, this particular surgeon likes to have the vein bridged, so that that's a series of multiple incisions, and the vein is tunnelled under each skin bridge. And the good thing about vein mapping is it can identify each tributary. So if you've got a big, fat, chunky tributary, better to have it over an incision that you can see and expose it and ligate it than have to tackle it under a bridge. So this particular surgeon insists on bridging, so it works perfectly there.
Yeah, another question.
Sorry, just this was regarding Angela's question about vein harvesting training and everything. For AXA, as a surgical care practitioner team, and SCTS have put an educational event because this was highlighted because we are not unable to go and learn. So we have a dedicated vascular scientist come for the courses and they train how to do the vein mapping. So this is one of the good course SCTS and AXA has put through. We run 3 times a year, so if anybody wants to come and train.
Could you book me on that course, please? Could you book me on that course?
Yes, of course you can, yeah. It's free of cost, everything is paid, and 5-star hotel for you to stay as well.
Fantastic. Another question?
I'm Richard, I'm a surgical care practitioner from Hull. We've had all the same problems and same dilemmas that you've had. Interestingly, you said the legs were assessed clinically, and then it depended on the ultrasound whether it changed your decision.
Yeah.
How are you assessing clinically?
In the way that we would go into the anaesthetic room, read the patient's notes, read the past medical history, and then assess the leg visually, palpate the vein. You can't always tell if the vein, but how many times does the vein bifurcate mid-calf, and you can't always tell. More often than I'm happy with, to be honest. But the good thing about vein mapping is you can see that immediately, and then you know that you can check the other leg. It's either a mirror image or it's perfectly fine, and then you have to go into the thigh, so it's much quicker.
Yeah,
But yes.
We scan pretty much every leg we do, and have done for quite a few years now. And I find it fascinating, the same problems, bifurcates there and everything.
Yeah.
We're undertaking an audit, and we're going to try and get somebody to go to the ward prior to that to assess clinically, and then we'll see how we change the decision on cleaning the anaesthetic. I don't know if you think your decision is influenced by the person assessing it clinically as opposed to the person assessing it ultrasound.
Well, I tend to think that Does it make a difference if you assess them in the anaesthetic room or on the ward?
Yeah. You could be biased, that's the only thing, by you assessing them clinically and then you assessing them with you both knowing the anatomy of them.
Well, the thing that we looked at, you know, I'm assigned to an operating list, and then I trot into the anaesthetic room, make sure I'm not thrown out, read the notes, look at the past medical history. Have we got any issues? Yes or no? Most of the time it's yes at Papworth. And then we'll have a look at the leg. Is it obese? Have we got any varicose veins? Have we got any tissue viability issues? Is the patient a diabetic? And then we'll palpate the vein. And then we would ultrasound. So usually our standard, unless otherwise stated, is to harvest from the left lower leg. That's the default setting, unless we've got reason not to. So that's generally what we do. So generally speaking, if the patient had varicose veins in the left leg, then we'd probably harvest from the right lower leg. That's generally our default setting. So the ultrasound, you know, would show, you know, is the left lower leg varicosed, or are they just superficial varicosities? So that's how we did it.
So sorry, I don't know.
Have I answered your question?
What I meant was,
I lost the
you're
list.
clinically assessing the patient. Yeah. Are you palpating the vein, etc.?
Yeah.
Or you're not?
In the normal way that we generally would.
We've
Yeah.
got time for 2 more quick questions, I think, if they're quick.
Hi, I'm a national surgical registrar at Papworth, and I work with Louise. In answering your question, the surgical teams do look at the patients before the SCPs, and there's a lot of conversations. So you try and highlight a lot of the problems before. And what Louise has shown very eloquently here is that you can do it even better using ultrasound. So you can identify patients who might benefit. So why not do it for everybody before you take out that risk, or you take out the potential for problem altogether?
One last question.
Hi, I'm a surgical care practitioner from James Cook in Middlesbrough. I ultrasound all of our surgical patients before the day of surgery. And I've noticed that the results of my ultrasound scanning sometimes change the conduit that we use in theatre. Just a question for you. If you're ultrasounding in the anaesthetic room at the time of theatre, have you encountered any problems with doing it that late in the day?
Yeah. You don't have the chance to discuss with the surgeon if there are any issues. I would much rather do it the day before, or even, ideally the day before, with the patient on the ward. They're awake, they can stand up. You can ultrasound the long and short saphenous and the radial artery if you need to, if there's issues with the saphenous vein. Yeah, definitely. You haven't got enough time to sort it out.
Louise, thank you very much indeed.
Thank you.